Beyond immediate metabolic effects, the sustainability and psychological consequences of time-restricted eating over months to years deserve careful examination. Follow-up studies tracking adherence beyond initial trial periods reveal substantial dropout and protocol modification as individuals encounter the social and psychological challenges of maintaining restricted eating windows. 6 to 12-month observational research combined with qualitative interviews illuminates both barriers to adherence and potential psychological costs that must be weighed against metabolic benefits. Adherence rates follow a typical decay curve, with approximately 40 to 60% of participants maintaining strict protocol adherence at 6 months and 25 to 40% at 1 year. The most common reason for discontinuation involves social eating friction, as restricted eating windows conflict with family meals, social gatherings, and cultural eating practices that typically extend into evening hours. Participants describe difficult choices between social connection and protocol adherence, with many eventually prioritizing relationships over eating schedules. A second adherence barrier involves simple boredom or inconvenience, as the novelty of the approach wears off and the daily effort of maintaining restricted windows becomes burdensome without ongoing tangible benefits. Notably, adherence appears higher among individuals who experience subjective benefits like improved sleep or energy compared to those following protocols primarily for weight management, especially if weight loss plateaus or reverses. The psychological effects show considerable heterogeneity. Most individuals who continue long-term report neutral or positive psychological experiences, describing time-restricted eating as a sustainable eating pattern that feels natural after adaptation. However, a concerning minority, approximately 15 to 25% in screening studies, show signs of increased preoccupation with food timing, elevated eating disorder symptom scores on validated instruments, or development of rigid rules around eating that interfere with quality of life. Binge eating episodes during eating windows increase in some individuals, potentially representing a response to perceived deprivation during fasting hours. Social isolation occasionally emerges as participants withdraw from evening social activities rather than violate eating protocols, a pattern particularly concerning in individuals with pre-existing social anxiety or interpersonal difficulties. Clinical implementation should include psychological screening, monitoring for disordered eating development, and explicit permission to modify or discontinue protocols if psychological costs emerge. Healthcare providers should remain alert to warning signs including excessive rigidity, moral judgment around adherence, compensation behaviors, social withdrawal, or preoccupation with eating timing beyond what the intervention requires. Time-restricted eating should be framed as an optional tool rather than a superior eating pattern, with emphasis that traditional approaches to health behavior change remain valid. For individuals with histories of eating disorders or current psychological vulnerabilities, time-restricted eating carries sufficient risk to warrant either avoiding entirely or implementing only with concurrent mental health monitoring. The field must resist enthusiasm that dismisses these psychological considerations as acceptable trade-offs for metabolic benefits, especially given that metabolic improvements typically remain modest and achievable through alternative approaches without these psychological risks.